All right. Well, since we have a tight timeline, maybe we should get going. Thank you, everyone, for joining us today. This kind of muggy afternoon. Hopefully, we'll get some rain. And the reason why I say that is because our speaker, Amy Joan Cook, is a community paramedic for Clackamas Fire District 1, and I'm sure she's pretty looking forward to the rain as well as this presentation.
Reasons.
Yes, many reasons. So we'll go through the presentations, and when there's a period for questions, please put them in the chat. I'll monitor the chat and work with the presenter to get those questions answered. If we don't have time, we'll be saving the chat, and then we'll get back to you with the answers to your questions if we don't have time during today. But I would like to kick it off and welcome Amy Jo, who's going to be our first speaker. Thank you so much, Amy Jo, for agreeing to present today.
All right, well, thank you for the invite. Naloxone administration is near and dear to my heart on a bunch of different levels, but mostly thank you guys all for coming. I think that learning about naloxone and why we use it, when to use it, who to use it on, and making it more commonplace is one of the most important things we can do in this day and age. I think I'll start by saying that this event is being hosted by the Clackamas County Naloxone Work Group, which is a subcommittee of the Opioid Task Force, which I actually get to participate in and I'm a part of. For today's goals, we definitely want to provide a better understanding of the whole continuum of care of substance abuse, from addiction to overdose, and how to intervene in there at any given point in time. We definitely want to decrease the stigma around naloxone and overdose and all of those things that go along with addiction, so we can help people be more aware and we can have a better understanding of when to use naloxone. We want to increase awareness around addiction and overdose, and hopefully in doing that, we'll be able to save lives. And by the end of this, we'll be able to let people know what resources are available and how to use them, and where you can go get naloxone, all of those kinds of things. So to begin with, we're going to have April talk to us. And April Heron, she's going to give us a public health update on opioid and other drug data. She knows all the trends and all the responses in the area, and she's really our data geek is what I like to call her, because data is really not my gig. Before we go to April, though, I just want to tell you, as a first responder, one of the key factors in having a successful outcome when we respond to an overdose is literally bystander participation. There's a lot of times where bystanders are really important. There's a car wreck and you're there to stop bleeding. That is awesome. Someone to call 911, someone to do CPR, all of those things. But I can't think of a single intervention that is more life-saving than the administration of naloxone. The time that is saved between the opioids, making it so someone can't breathe, and 911 arriving is literally the difference between life and death. And no matter how good we are at our jobs, if we don't have that first person administering the naloxone and giving that person the ability to breathe again, we don't really have a chance. And so people learning about naloxone and being willing to participate is near and dear to me as a person, but professionally, it's a very big ordeal. So without saying any more, here's some things about April. April Heron is the program planner for Clackamas County Public Health Division, where she leads the work of the Opioid and Other Substance Overdose Prevention and Response Initiative. She enjoys working with her partners, which I happen to be one of those, that respond to the impacts of substance use in the community and the goal of helping our most vulnerable. April co-convenes the Clackamas Opioid Task Force and serves as the project coordinator for Project Hope, which I'm also a big participant in, and that provides support for overdose survivors when they're navigating that rocky road to recovery. So April, I'm gonna mute so you can start.
All right, thank you, Amy Jo.
That's still gonna
think we have enough.
Hey, you have a little bit of feedback, April.
there.
How's that? We're in the same room.
All right, well, that's easy. I'm gonna close.
Okay, there we go. I think we got rid of that go. Okay, hi everyone. Thank you so much for being here today. I'm April with the Public Health Division for Clackamas County. And I just wanted to mention I've also been a member of our naloxone work group for a couple of years now, and it is really a pleasure to work with the folks who serve on that work group, and it's just been one of the favorite parts of my job. And so getting to put events like today's together is just something that I really look forward to. So thanks for being here. And part of what I'm going to do today is to frame up the conversation for today's event about naloxone, but also a little bit about what we've been seeing with regard to the opioid crisis over the last several years. So here is a picture of what we've been seeing with the opioid crisis as it's been unfolding over the last 20-ish years. What we've been seeing is the opioid epidemic come in waves. That first wave started in the late 90s and included OxyContin and the rapid spread of prescribed opioids. We then moved into that second wave, which hit around 2010. And we moved from prescription pills to a rise in heroin deaths. And we're continuing to see that even still today. And that third wave came around 2013 and involved fentanyl and other synthetic opioids, which are proving to be extremely fatal to people. So that's that steep line that you see there, that black line rising up. That's led to a significant increase in deaths that we're, again, still seeing today. And then the fourth wave is really our most recent wave. And that is really what we're calling a polysubstance use wave. And that is the widespread use of illicit drugs like meth and cocaine, other drugs like benzodiazepines alongside opioids. Okay, so next slide. So unfortunately, what we now have is two intersecting epidemics with the emergence of COVID-19. And this is showing us that our response really needs to be quite different than what we've been doing before. It's going to require not only a unique response, but more resources than we were having to put forward pre-COVID. Before COVID, addiction was costing Oregon taxpayers about $6.7 billion annually. That amount is going to continue to grow as the effects of COVID-19 have increasing impacts on our populations, not only on those who had a substance use disorder pre-COVID, but you can imagine the number of people who have developed a new substance use disorder during COVID and will go on to develop one as new waves of COVID emerge. So some of the urgent responses that are needed to address both of these worsening epidemics and the underlying factors are things like responding to social isolation, disruptions to our treatment and support systems, and just responding to all of the different traumas that have emerged, economic impacts like job losses, homelessness, and then people who have lost a family or a friend, and not only to COVID, but to other issues as well during COVID. It's been a very, very trying year and a half for most of us. Okay, next slide. So some of you might have seen the latest news about the overdose numbers that were released just a couple of weeks ago. It's not good. We hit an all-time high for drug overdose deaths at about 93,000. This includes provisional data from the National Center for Health Statistics, and it's the predicted number of deaths from January through December of 2020. So they're technically still finalizing those numbers. And that death toll jumped by more than 21,000 from 2019 to the end of 2020. That was a 30% increase. That is huge and very devastating. Next slide, please. So Oregon saw about that same percent increase. It was right around 30%. So we're not the worst, but we definitely weren't unaffected. We're kind of hovering right there in the middle. We went from 613 deaths in 2019 to just about 800 in 2020. And overall, opioids, primarily illegal fentanyl, continued to drive that death toll. So that's probably not very surprising to many of us who have been in this field for a while now. The overdose deaths involving just opioids reached over 69,000, and that's up from 50,000 in 2019. Deaths from methamphetamines and cocaine also rose. And the National Institutes on Drug Abuse, I thought this was really interesting. They report that fentanyl has so much infiltrated the illegal drug supply in the US that 70% of cocaine overdose deaths and 50% of meth overdose deaths involved fentanyl. Okay, next slide. So locally, these are a couple of the new dangers that are thought to be contributing to the increase in deaths, and they're coming in the form of counterfeit pills. There's a couple pictures of them on the right. The M30 pills are meant to appear like a pharmaceutical grade painkiller, oxycodone. And the Xanax bars are down on the right. And these are presenting as Xanax, which is an anxiety medication, equally as dangerous and oftentimes contain fentanyl. And then what I don't have pictured here are the E7 and E8 pills. I just started to hear about those. I'm sure some of you on the call have as well. They are a counterfeit pill containing cocaine and a new analog of fentanyl called psychopropylfentanyl. And I'm hearing that that is not responsive to fentanyl test strips, but it is responsive to naloxone. So that's good. One thing to know about these counterfeit pills is that they're so well made that even experienced users say that they cannot tell the difference between what's a fake pill and what is a real pill. But many times they are laced with fentanyl, which is 100 times more potent than morphine. And oh, I just lost my place. Give me 1 second here. So the amount of fentanyl can vary from pill to pill, even in the same batch. So just 2 milligrams, which is the amount there next to that penny in that picture, and the weight of a mosquito could mean death for people. So this is very, very dangerous. And even people who have a high tolerance for opioids face just as much of an increased risk of death. Okay, next slide. So the public health divisions across the Tri-County areas are continuing to monitor overdoses weekly using surveillance data from first responders. So what you see here, that bottom line on the red includes EMS response data from both AMR, who work in Multnomah and Clackamas counties, and then Metro West, who comes out of Washington County. And then the top line, the blue, is our emergency department and urgent care visits. So overall, our region has seen an uptick in both the non-fatal and the fatal overdoses based on not only this data, but additional sources of data that we're looking at. And this has prompted our Tri-County Health Officer team to raise our overdose surveillance to what we're calling a caution level, which is yellow. Green is kind of just our standard, everything's proceeding according to the levels that we've seen for a while across the board. And then that next level beyond yellow would be sort of this red. There's definitely something happening and we definitely need to get a lot of alerts out. We are continuing even now though to get alerts out to our partners and our community, just letting them know about some of the dangers that we're seeing. Okay, next slide. So this is EMS transport data for Clackamas County. And this transport data that is also something that public health tracks geographically. You can see it spans both rural and urban areas, although there are more clusters in the densely populated areas. And I want to note that this map doesn't include data from all of our transporting agencies. I think it covers about 4 out of, I think we have maybe 7 or 8 total. So it very much underrepresents overdoses happening across the county, but it is the best of what we have right now. And we're always continuing to work to improve our data sources and our surveillance. And one way we're using that is to help guide the responses that need to happen in the different parts of the communities, and for also gauging areas that are experiencing new or heavier burdens. For example, we're really starting to see upticks in Wilsonville. That wasn't an area of the county that we've typically seen overdoses in before. So it's really signaling us that maybe we need to provide more supports and attention out in that area of the county. Okay, next slide. So looking at drug-related deaths from our medical examiner data, you can see the differences that we're seeing here, just that jump from 2019 to 2020. We went from 40 people who died with drugs in their system to 60. And then so what we have for 2021 is slowly rolling in. We have 23 confirmed deaths so far. Those are deaths that mostly go through about May. And then we have 11 reports that are pending for May, June, and July. So it's not looking to be very good if we stay on that same level of what we've been seeing for the first part of the year through the rest of the year. We will likely surpass 2020. Next slide. And I'll wrap it up here because I know I'm over time. This chart just shows the type of drugs that we're seeing in the toxicology reports that are coming in from our medical examiner. And you can kind of see how those trends have changed since 2019 as well. The presence of opioids and the results of people who died in association with substance use increased 48% overall from 2019 to 2020. And the deaths specifically related to fentanyl tripled from 2019 to 2020. Those from heroin increased just slightly, and methamphetamine fatalities remained about the same. So far, the trend for 2021, which you can see here, is showing us that an increase in deaths from fentanyl is really probably what we're going to be keeping our eye on. So far, they've doubled what we saw in 2019. So that's huge so far. Okay, and this is my last slide. These are just some recommendations that are continuing to drive the work that we're doing, continuing to expand naloxone distribution and overdose prevention education, which is one reason that we're all here today. Expanding awareness and access to treatment for people with a substance use disorder. So it's really about supporting people in getting them to those access points. Intervening early with people who are at highest risk for overdose. We do a lot of work with people who are justice involved in coming out of our county jail. And then lastly, just continuing to improve our surveillance and data so that we really know the areas of the county where we need to most focus our attention. And with that, I will go ahead and pause. And if there's any questions, I know that we do have some time reserved at the end, and I'm also happy to answer any questions in the chat. So thank you very much, and I'll let Amy Jo introduce our next speaker.
So I have to be honest with you and tell you, April, that your data is frightening. As a 911 provider, I can tell you that in Clackamas County alone, our calls for overdoses have increased by, at least tripled. And I know that unfortunately, a lot of those have ended up in death. So as much as I give you grief about data, those are some frightening statistics. Hopefully, though, with our next presenter, Abigail Wells, we'll be able to talk more about prevention and hopefully change that data trend and go on the downhill slide. Abigail Wells is the Prevention and Community Public Health Department Manager for Northwest Family Services and oversees the federally funded Drug-Free Communities Vibrant Future Coalition. Abby is an alumna of Menlo College in Atherton, I think that's how you say it, California, where she received her Bachelor of Arts degree in Psychology and Humanities. After this, she returned to her lifelong home of Portland, Oregon, where she earned her Master's degree of Arts of Teaching at the University of Portland. Abigail began her career as a language arts teacher before moving into the field of prevention, where she has remained for the last 10 years, and I hope she stays there a lot longer. She earned her Certified Prevention Specialist licensing along the way. Abby, why don't you take us through some prevention stuff?
Yeah, thank you. So again, my name is Abigail Wells, and I'm Prevention and Community Public Health Department Manager for Northwest Family Services. I'm going to kind of speed through this as I don't have a lot of time. So first of all, what a lot of people know about prevention is the what's not accurate today, and that is kind of the war on drugs. There was the Reagan administration that coined the war on drugs, and then also anti-drug campaigns such as the Just Say No campaign, which everybody is familiar with, and a lot of people think still today that most of what prevention is us being in classrooms teaching youth to just say no, when in reality we do classroom presentations, but that's just a tiny piece of the puzzle, and we actually do in prevention a whole lot more than just classroom presentations. It's a small percentage of what we do now. Go ahead. So first of all, prevention and public health are very, very similar as far as the models that they're rolled out after. So I just wanted to show the similarities between the strategic prevention framework, which is the one for prevention, and then the public health. I forget what this one is called, but the system management system. Go ahead. Same thing with the health impact pyramid of public health. As you see, it's very similar to the spectrum of prevention. So in a lot of ways, public health is prevention and prevention is public health. Go ahead. So there's 12 sectors that we represent in the prevention community. So everyone who is involved in the coalitions and things like that come from various sectors of the community, and we'd like to have them all working together with us to be able to serve the community in a holistic fashion. So we have everything from parents to youth to healthcare professionals to county folks, so government, business community, and others that you can see there. Go ahead. So there's 6 CSAP prevention strategies. That's information dissemination, prevention, education, skills and training, alternative activities, community-based processes, environmental or social policy, and then problem identification. Go ahead. Then we have the 7 strategies for community change, which is what we kind of base our action plans and things like that off of. The 7 strategies is a diverse range of strategies that create population level change, focus on a problem behavior. The lasting behavior change requires a focus on community systems, policies, and local conditions to affect the environment where youth marijuana use or other substance use may occur. It's a tool to think systematically about how to address local conditions. It's strategies that work together comprehensively, and a tool to help align problems, root causes, and local conditions. Go ahead. So I just wanted to go through some examples of the 7 strategies for community change, that some of the things that we do for prevention or have done. So as you can see on the right, there is that instructional component. We have parent-student nights that was engaged for a vibrant future. We also hold trainings like this, the Not Just Naloxone, and we have a variety of other trainings and in-class presentations and things like that where we provide information. It's also media campaigns. So you could see there on the left, or maybe, yeah, there's the accidental overdoses happen. It's a naloxone billboard that we work together with the county to design and put up at 3 locations in the Clackamas County area. And then you see the shirts that were shirts we gave out to students in the school that said 74% of youth don't drink alcohol. So it's a community norms approach. So it's all information dissemination or providing info. Next. Enhancing skills is the next thing. So enhancing skills is giving people a skill set and things to improve upon or just helping different programs and things like that. So this Not Just Naloxone presentation is an example of enhancing skills because we're giving you the information on how to administer naloxone. We also take kids and youth to leadership opportunities. And then in classrooms, we have opportunities for them to create like safety plans and prevention plans for their work in the classroom in regards to substance abuse. And we do harm reduction as well in the classroom. Providing support. So we provide support to a lot of different places and a lot of different work groups. And some of those are like the OPHA, it's the Oregon Public Health Association Addictions Prevention Section. So we provide support to them I'm on their board, and a bunch of us are on their learning committees and their connections committee. We provide support to, there's the Pick Our Brains, that was a collaboration. So any collaboration is us providing support to the county or things like that. We also do a Unity Club, which is a youth focused club that focuses on prevention and also LGBTQIA+ initiatives. Go ahead. Enhancing access, reducing barriers. So this is creating things, trying to reduce barriers for people who are accessing our services. So creating things in Spanish as well as English, and posting social media posts in Spanish as well as English, providing transportation, whether it be bus tickets or actually transportation in our cars or on the bus that we have, or providing childcare, things of that sort. Okay. Changing consequences. So changing consequences looks like working with the OLCC to do checks, to do license checks at mini marts. Working with Stumptown, we did a lot of changing consequences by changing the format of what's in the house and providing lock boxes and things like that. We also created this document to send out when they were doing compliance checks, and we sent it out to all of the local marijuana retail shops that basically talked about how to prevent sale to minors and to stay in compliance. And so when the first compliance checks came out, there was like 40% compliance in another county, but by the time they got to us, we had 100% compliance, because we give them the information that they needed to stay in compliance and what that looked like. Go ahead. Changing the physical design, so actually changing the design of a location. So we have 2 boxes, medication drop boxes that we've helped get into Fred Meyer's and Walgreens in the areas. We also changing physical design is also kind of like I mentioned before, changing the physical design of someone's home environment. So providing lock boxes, we have alcohol locking tops that we provide. So things that make the environment different. We do marijuana safety stations. So on the right, you'll see a little bit about the safety stations, and they have everything from posters to lock boxes to compliance signage and media recognition, things like that. Tips for parents, all these things within a toolkit that we provide to the cannabis locations, and then they put in these things and we bring them to them so it makes it easier, one step less for them to have safety stations in the stores. Go ahead. And then modifying, changing policy and procedures. So we work a lot with local governments and county government and even the state government to work on laws and legislation and different bills to give public testimony, written testimony. We even take it through OPHA to get endorsements of this particular bill, since we can't technically do that. We've also had trainings that we put on, like Amplify, which is a training for policy and advocacy that we put on not too long ago. Go ahead. So that's all that I have, just some rundown of kind of prevention and what it kind of looks like as opposed to what it used to be. Are there any questions at this point?
That was wonderful, and we're probably going to save questions to the very end. We did allow for some time in there. Abby, your programs that you're a part of and the ones that you talked about are amazing. I think you've done an incredible job trying to target everyone's different personalities and get rid of barriers and really get people to not even engage in you know, drug behaviors before they even start. And we even have to deal with overdose and using naloxone and stuff like that. On the offhand that we do have to use naloxone, though, our next presenter is going to be May Yates. And she's going to talk to us about not only overdose awareness, but about the actual administration of naloxone. I do want to tell you guys, I know that especially after this one, we always have a lot of questions. And so there will be time at the end, and there will be a video at the end that's going to talk about, you know, the real administration and go into a little bit more depth. But one quick thing I want to tell you is that, one, administering naloxone is easy and it saves lives. Two, if you give it and someone doesn't need it, it doesn't matter. And I'm going to say that again so everyone in the back row can hear me. If you give it and the person doesn't need it, it doesn't matter. But if you don't give it and they do, the person will die. So if that helps you make a decision or gives you the confidence to get involved, then I hope that you listen to that, because it's really important that people understand that it's okay to get involved. And it is no more harmful than handing someone a Band-Aid, and it can save a life. So it really makes a difference. I'm going to turn this over to May, but I want to tell you a little bit about May first. May is the Prevention and Policy Coordinator with Vibrant Future Coalition, a coalition devoted to youth prevention in North Clackamas and East Multnomah counties. She received her master's degree in child and family policy and worked in the juvenile justice field before making her way to prevention. May has seen how prevention work can be pivotal in a young person's life and how important it is to educate youth early on. She is passionate about harm reduction and supporting other folks in these important conversations. May, take it away.
Awesome. Hi, everyone. So I'm going to talk about overdose awareness and naloxone administration. So briefly, I'm going to have a poll go for whether or not you think a few statements are myths or facts. I'm going to go over some risk factors for overdosing, how to recognize an overdose, how to respond to an overdose, and then I'll go into naloxone. So first, I'm going to pull up a poll for everyone, and I'm going to give you about 2 minutes to answer these questions, and then we'll go over the answers. So if you all could fill that out, that'd be great. Give you all about another 30 seconds or so. All right, I'm going to just go ahead and close the poll so we can move on. So it looks like a lot of people, are the answers to these. So I'll go over the answers really quick. Let's see. So the availability of naloxone encourages drug use and discourages people with substance use disorders from seeking treatment. So this is false. The thing that keeps people from seeking treatment is dying. And so by reversing an opioid overdose, you're giving someone another chance to go to treatment if they so choose. The second is naloxone is another drug. Naloxone is another drug that can be abused. So this is also false. You cannot abuse naloxone. It is safe and effective, and you can't abuse it. In addition, naloxone cannot be taken before drug use to avoid an overdose. If a pregnant person, a child, or a pet gets into the naloxone, they will not be harmed by it either. Overdoses are more likely to happen in long-time users. So this is actually a fact. Overdoses are more often in people who have used for 5 to 10 years of experience. There's a variety of reasons for this, and I'll go over some of the reasons for that in a little bit. Naloxone is a self-administered treatment. So this is a myth. Someone who is overdosing cannot give naloxone to themselves because they would be unconscious. But it is really easy for a friend or family member or a bystander to administer that to the person. Naloxone is dangerous if accidentally ingested by my child or pet. So like I said, this is a myth. It only works for people who have opiates in their system. Basically, all it's doing is going onto your opiate receptors and popping off the opioid. There is a very, very, very small chance that you could have an allergic reaction to it, but that is very uncommon. Naloxone will not work if the person overdosed on something else. So this is true. Naloxone only works for opioid overdoses. It does not work for other drugs. So Xanax, Valium, meth, or cocaine, it would not work for. If you're using with someone and they start overdosing and you call for help, you will not get arrested. So that is a fact. We have a law called the Oregon Good Samaritan Overdose Law. So if you were to administer it onto someone, you cannot be arrested or prosecuted for any drug-related charges or for violating probation or parole because of drug use or any outstanding warrant for drug use or possession. So use it. Use it if you think someone's overdosing. You will be safe because of this this law. And then naloxone is difficult to get. So this is a myth. Now, you know, the county has it. There's a lot of, I'll go over some of the ways that you can get it at the end of my presentation, but it is much easier to get now than it used to be. So let's see. I will close out of this. Awesome. Alrighty, so I'm going to go over quickly the Oregon Good Samaritan overdose law. So like I said, it does provide immunity from the following offenses if someone were to call 911 in good faith in the event of an overdose. So if you were to see someone overdosing, you could not get in trouble for possessing drugs or drug paraphernalia, being in a place where drugs are used, violating a probation or parole agreement stemming from a drug charge, outstanding warrants for drug-related charges listed above. However, it would not provide immunity from being arrested for any other kind of crime, any out-of-state or federal warrants, or any other new crimes not listed above. So DUIs, child abuse, that sort of thing. So some risk factors for overdosing. So one is mixing drugs, alcohol and like Valium, benzos are very common ones that people mix with opioids, and it does increase your risk of overdosing dramatically. Reduced tolerance. So if someone were to go sober, someone went to jail for a little while or was hospitalized or in treatment, and then they start using again, that is a risk factor for overdosing. Unfamiliar supply or changes in quality. So if a person uses a new dealer or the dealer gets a new supply, it's much more likely to be laced with fentanyl or, you know, cut with something else. Having someone else inject you, this is because if you had someone else inject you, you're at the hands of how much they end up giving you. So this can be really dangerous. And then using alone, this is really dangerous because if someone were to be overdosing and they're living or they're using by themselves, then there's no one there to administer naloxone if they needed it. Okay, so how to recognize an overdose? So it doesn't always happen right away. It can happen up to 1 to 3 hours after injection. And some of the telltale signs of overdose are blue lips and nails, unresponsive when you call their name, shake them or tap them, or slow, shallow, gurgling breaths. So one thing that some people do is, you know, if you try to shake them and they don't respond, you can yell something like, I'm going to give you naloxone. And if they're still unresponsive, that's a good indication that they may be overdosing because they are unconscious. And often people who are on opioids don't want to be given naloxone, which I'll go over in a minute again. But before you are to help this person, make sure that you are safe. Check the area for any hazards. You're not in traffic. There's no unsecured needles. There's no big unsecured dogs. You can't render aid until it's safe because otherwise, you know, you're in danger yourself. So do make sure you're safe before doing anything. So the steps to respond to an overdose. So now you've determined that someone may be unconscious and that they may be experiencing an overdose. So here's what you need to do. So first, you need to attempt to wake them. You know, say, "Hey, are you okay?" You can tap them, yell at them. Make sure, to see if they're breathing. That's when you can yell like, "I'm going to use naloxone," and if they don't respond, that's a indication that they may be overdosing. Then make sure you call 911 and put the phone down. So you can make sure EMT is coming. And then start doing rescue breaths. So if the person's not breathing, they have about 5 minutes before they can die. So just start giving them rescue breaths for at least 30 seconds. Because they're not breathing, you need to be breathing for them. Then you would administer Narcan or naloxone. Narcan's a type of naloxone. So if it's the nasal kind, which is the kind that we currently have, you would insert it into either nostril and then you plunge the dose into the nostril and keep their head tilted back. And then you go back to those rescue breaths. It can take about 1 to 3 minutes for the naloxone to take effect. And then if they're still not woken, you can give them another dose of naloxone. So they are finding that more and more people are needing multiple doses of naloxone before coming out because the opioids are so strong right now, especially with that fentanyl. So all of the kits that we make at the county, all have 2 doses of naloxone for that reason. And then make sure you stay with them once they rouse. So oftentimes people don't want to go with EMS. They don't necessarily trust them. And naloxone only is effective for 30 to 90 minutes. After that time, the person can overdose again, especially if they use during the time that they had the naloxone in their system.
Hey, May, someone was asking in the chat if the same nostril for the second dose.
I believe you can put it in either nostril, but typically we say put it in the other one. Let's see. So naloxone is a safe antidote to opioid overdose that has no risk of misuse or dependency. All it's doing is binding to your opioid receptors in the brain, and then it temporarily prevents overdose. There's no danger in administering it if someone isn't overdosing, and there's no danger for children or pregnant people either. So if you are unsure, use the naloxone because it won't hurt them. It will only save their lives if they need it. So I will be showing this video at the end so if people want to stay on, you're welcome to watch it with us. Otherwise, I'll link it in the chat as well and you can watch it on your own time. But a few things that are really important is If you need to leave the person at any time, put them on their side so that they don't end up vomiting and aspirating. And make sure not to give really intense rescue breaths, because that can also induce vomiting, which can cause aspiration, which is very dangerous as well. And then let's see. So once the person wakes up, you've given them the naloxone and they've woken up, they're going to be confused. You might have to repeat what's happened, reassure them. One thing about naloxone is that it makes the person feel like they're going through withdrawal. So they might be agitated or disoriented. And oftentimes they have headaches, nausea, vomiting. They may be aggressive. These symptoms, like I said, they only last for that 30 to 90 minutes. So it is really important during that time to not let the person use opioids, because they're not going to feel it until after they come off the naloxone, and then it can cause another overdose again. So yes, so one thing you can say to a person is, if you use drugs right now, you're going to be wasting them. Wait until after the naloxone is gone before you start using again. And yes, like I said, taking more drugs could cause another overdose once that naloxone wears off. It's very important to stay with someone for a while to ensure that they don't use again or return to an overdose after the naloxone wears off. So that's very important. And then my last slide. So some of the places you can get naloxone. So you can get a prescription from the pharmacy. This can be expensive, so just be aware of that. Some other places are the local syringe exchange sites, which we will send out an email after this training with where those sites are and their hours. And then the last one is Clackamas County Public Health has some naloxone kits. There is a form that I will also link in the chat in just a minute. We can also provide PPE, fit packs, fentanyl test strips, and naloxone trainings. So if you work for an organization and would like naloxone training, we are happy to do that as well. So does anyone have any questions?
This is what it looks like, if you can all see it.
Yes.
All right, May, thank you so much for that information.
Yeah.
I know that it seems like she went over that really, really fast, but I'm going to tell you, it's just that easy. It literally is, sticking it up the nose and pushing the button, and it saves lives. She touched a little bit on allergies, but I'm going to tell you that it's always a bit of a concern. But here's how we weigh out risk versus benefit. Okay, if the person is not breathing, they're going to die. So whether they have an allergic reaction to the naloxone or not is something we can deal with later on. But the immediate thing is that someone's not breathing. And so we're going to give them the naloxone and then deal with what comes after that when it comes after that. So thank you so much for that really great information. And I hope you all never have to use the naloxone, but I hope if you're in a situation that videos like this and presentations like this give you guys the confidence to go ahead and step in. Our next speaker is going to be Allison Noyce, and she's going to talk about the relationship between harm reduction and the treatment of substance use disorders. Allison is the executive director for CODA. She's led the community behavioral health programs in the Tri-County area for over 20 years. In 2010, she began directing CODA's medication-assisted treatment programs, growing with the organization, and eventually becoming the executive director in 2019. Through all of her work, her passions have been finding ways to change how we understand those members of our community who most are deserving of our compassion and have a voice of their own. I can say personally, I have referred many people to CODA, and people have had a lot of success there. So Allison, I look forward to hearing what you have to say.
There we go. I'm looking at too many screens. I apologize. You guys can see my slides okay, yeah? Somebody just nod at me. Okay, great, thank you. Yes, again, my name is Allison Noyce. I'm the executive director at CODA. I'm so happy to be here. Thank you for the invitation. And thanks, Amy Jo, for the kudos. I really appreciate that. As the quick bio mentioned, I have been in behavioral health in the Tri-County area for over 20 years. I came to CODA in 2010, which you'll recall from April's slide was when we reached the second wave of the overdose epidemic, and heroin overdoses started to increase dramatically. So I've had the really great fortune to be doing some pretty amazing work in a pretty unfortunate time. So I wish I could invite as much conversation and questions as possible. I'm going to try to respect people's time that are presenting after me, but please, if you have thoughts, observations, questions you want to throw in the chat, and if Elizabeth or May can interrupt me, I'm happy to do that. So I want to talk a little bit about how harm reduction and treatment really complement each other. I think if I reflect on some of my earlier time in behavioral health before I was in addictions treatment, even when I started addictions treatment, I think the assumption is often that they are one or the other, or that there are these sort of hard boundaries around somebody's either interested in or engaging in harm reduction oriented services, or they are in treatment. And I find it so promising to see how that sort of dichotomy is really breaking down, and the blending of harm reduction and treatment is just, I think, such a tremendously positive change for our field, and also something that I think not a lot of people yet understand is how the field is shifting. So again, super happy to be here and probably using up all my time already. All right. We've touched on this stuff a little bit already. Obviously, the record number of overdoses are quite distressing. I do think it's important that folks know that those overdose increases are not exclusively about COVID. We were seeing those increases begin in 2019. So obviously, the introduction of fentanyl, the increase in fentanyl on the West Coast really had a lot to do with that. Any number of other social conditions, presumably. Obviously, COVID then sort of blew some of the risk factors just really out of proportion when it comes to overdose deaths. And so as a treatment provider, when it became clear the moment was we all needed to sort of isolate from each other, those of us who work closely with anybody who struggles with a substance use disorder was rightly terrified. The recovery is about building community, and the idea that community had to sort of break itself apart in order to stay safe was, a moment that I hope to never relive in my professional experience. It also, as I believe or somebody has also mentioned, isolation is just straight up a tremendous risk for overdose. So people who are actively using drugs and people who work with people who actively use drugs often encourage not to use alone because you obviously, as we just understood, you can't administer Narcan on yourself. So the isolation impacts to the overdose risk was just pretty astounding. And obviously with COVID, the provider access became quite uneven, but also I think not quite as bad as we thought it would be. But I think the fear of was it safe to go to treatment? The question mark of is treatment available? And also, I'll just sort of throw it out there. I think COVID was a lousy time to try to get sober. So it was a hard time to feel like not drinking, or, we were all talking so much about increases in alcohol sales and just the despair. Initiating treatment is an intimidating moment, and I'm very appreciative of how hard that likely was for a lot of people to think COVID was the time to do that. That said, despite all these sort of daunting factors, there's a lot of opportunity in front of us today that I haven't seen until the last year or so. There's a lot of public conversation about the language that we use with people who, when we talk about people who are experiencing substance use disorders. If you Google "say it nicer," you'll find a Forbes article that's really nicely written that includes an interview with Hunter Biden, and just, really is about why it's so important we start changing the way we talk about people who use drugs and people who are in treatment and people who are in recovery. It actually has a tremendous amount to do with whether or not somebody even wants to initiate or sustain any kind of recovery. We're seeing a ton of state and federal priorities shift toward not just treatment, but also to harm reduction resources and promotion of harm reduction. And within those priorities, and also in any number of ways, where the value of lived experience and the voice of people, not just who are in recovery, but who are still using drugs, is getting a platform that it deserves, and is being sort of held up in areas of advocacy and political change. Well, more than just the idea of helping people into treatment, we're really changing the way that we acknowledge what's important about the voice of people who use drugs. That sort of just blows me away sometimes when I think about where it was 20 years ago and where I was 20 years ago. It's been really amazing to be a part of how this field is changing. So speaking of this, I just found really interesting. So in a matter, like literally within 2 days of each other, both the New York Times and the Atlantic posted some very nice guest essays that were specifically about harm reduction, about the value of syringe exchanges. And it was just so, again, nice to be reading in these really sort of prominent publications that people are just talking about drug use in a very matter-of-fact way that I think we haven't seen in quite a long time. And both of them really emphasize giving how harm reduction is about giving power back to people who use substances. The very first sentence of the New York Times article, well-established science writer, was, the first sentence is, when I was using heroin in New York City in 1986, right? We didn't talk like that about people who, a person who used drugs often doesn't talk about themselves that way. And so that we're shifting the perspective and the promotion of this, I think is fantastic. So again, I've been doing this work for a while. I started in 2010 managing CODA's methadone maintenance program. It has since expanded to other medication-assisted treatment. But it was a very different room that we were talking in. And often, so anyway, sorry, I'm not going to go there yet because my time is short, but I do want to sort of run through some statements here in this next slide that, again, this would be a great moment if I had some audience participation. So by all means, throw anything up if you feel like it. What I have learned in the years that I've been talking about medication-assisted treatment and more so harm reduction, I think venues like this are really essential, and often we're sort of, we might be preaching to the choir, right? This group is here because you're already interested, and there, on some level, there's a part of you that believes there's value here. I also think it's really important to acknowledge, like, it's easy to feel like you're supposed to say the right thing and you're supposed to say, yes, of course, this is the right thing to do. And if we're going to change the way we approach people who use drugs and the way we understand treatment, it's okay if you don't have the right answer, if you don't have the answer that like everybody thinks you're supposed to have. I really encourage people to sort of sit with statements like this, with these kinds of ideas, and really figure out like where your position is. When I first was asked to come run a methadone clinic, I thought absolutely not, right? Because nobody had taught me what that was yet, but it wasn't a palatable thing to say either. So it's just a little bit of an aside for me. But so this next slide are a series of things that I've heard people say over the years, and I just kind of want to let you guys spend a second with them, and then I'm gonna talk a little bit about each one of them. And I'm blowing through, I have like, what, 2 minutes maybe? All right. I think we touched on the first one in May's presentation already, but these are things that I hear people say, that I've heard people say any number of times over the years. I'm going to say this one in quotes because I can't say it it's hard for me to say. Giving an addict a syringe is like buying an alcoholic a bottle of whiskey. Unlimited naloxone access encourages people to keep using. People who use medication-assisted treatment aren't really in recovery. The goal of treatment is abstinence. Again, like just there, you can have whatever answer you want to any one of these questions. I'm not here to tell you what the right answer is. I'm here to help you surface what you might not even know is an assumption that you already have.
Allison, I just want to pipe in for a second. You have until about 10 after, so you're just fine on time.
Yes, super, thank you. That means anybody that wants to throw something in the chat box should do that. Okay, but I will move on to the next slide. All right, first one. Before I put up the sort of the answer to this one, I have to just really tell you, it was very hard for me to write this first sentence. I don't use the word addict or alcoholic anymore. And when I mentioned earlier the Google say it nicer, that's really what this is about. A person who uses, abuses, is physically dependent on alcohol is not an alcoholic because they're still a person. They're a father, they're a brother, they're any number of things, and they're not just sick 24/7 hours a day. So I think it's really important that we figure out how to talk about people who use drugs and alcohol in ways that don't separate them from their own humanity. So I put that sentence up there with like a lot of like actual physical reaction. Anyway, syringe services increase the likelihood that people will reduce or cease their use and or enter treatment by up to 5 times, right? So the idea of a syringe exchange is not just about reducing the harm, and that should be good enough if that's all it is. If all that somebody benefits from a syringe exchange is not using a needle that might spread infectious disease, fantastic, good on them. If that happens to be the moment that they intersect with the desire to enter treatment, even better. So they are absolutely entry points into treatment, and they absolutely don't have to be either. Unlimited naloxone access encourages people to keep using. This one I love, right? Because we talk about, as naloxone started to get distributed around the country, and particularly in law enforcement jurisdictions that were really unsure about it, you heard a lot about like, well, you can have it once, or we'll have pharmacy benefits that are like, well, you can only get it like so often. Naloxone should be like the bowl of condoms that you see in any number of bars, and it should be like the candy jar at the front desk, right? It should be everywhere, and there should be no judgment over who gets it, how often they get it, and whether or not they get it again. The reality of it is, as Amy Jo has mentioned, I think every time I've heard Amy Jo speak, which I appreciate, every time you administer naloxone, that person stays alive, and that's critical, right? A dead person, for lack of a better term, can't ever get better. So all the naloxone all the time is really where it should be. And I think one thing to appreciate also is we often think about naloxone distribution practices as about for the person who is at high risk of overdose. Often the person you gave naloxone to is going to use it on somebody else, right? It's not about I use drugs, so I carry naloxone. It's I use drugs and I'm around people that use drugs. More often than not, any one of us might need naloxone. And so the more it moves around, the more likely somebody is to benefit from it. I can't help but throw in the oldie but goodie. People who use medication-assisted treatment aren't really in recovery. By and large, this is happening less and less often, but I still like to point it out. you know, not just because I want to argue the science of medication, but because, and again, this is where I really feel harm reduction principles and treatment are sort of coming together in such a great way. Like, we as treatment providers have to stop telling people what the end goal of treatment is, right? So the person who achieves what they want to call recovery, however they got there, fantastic. Is their life better? Great. Do I have any right to prescribe whether or not they did it the right way, or whether or not it is really true recovery? Absolutely not. I want more and more often for us as treatment providers to be having conversations with our patients, our clients, about what is it that you want, not how do I help you stop using drugs. So to that end, the goal of treatment is not always abstinence, and that's okay. And if a treatment provider sort of can't tolerate that, I have kind of a problem with that. But also, I think it's about people who are curious about recovery, about treatment, have to understand, like, you don't have to fix it all in one fell swoop, right? You don't have to be 100% motivated to be sober 100% of the time and benefit from treatment, right? The goal of treatment is whatever that person wants to get out of treatment. And then it's my job to help them see how they can get there. And if I have an opportunity to help them be more ambitious about what the value of abstinence is, I will take that opportunity. But I'm going to start with what that person wants to be different in their lives, and whether or not changing the way they use drugs is going to help them get there. Okay. So tons of good progress, like I say, that's really happening. I think the way the treatment field is shifting, the way harm reduction is becoming more commonplace, and the way they're sort of weaving themselves together, it gives me a ton of optimism about how more and more people can benefit from any amount of recovery. But you know, there is still a lot of work for us to do broadly, right? Again, this is a group. I'm going to assume that the group of people that are attending this Zoom today have some motivation to help people be sober, have some interest in the person that's trying to recover. And the person who believes all those things that I wrote on that slide, I don't think is here today. And if you are, I'm so glad you're here. So I really want to just encourage anybody that's listening today to take some of this away and think about, you don't have to change everything. You don't have to believe everything I said, but think differently about the language that you use, and think about how we can help more people get a little closer to a better life. Again, it's about the quality of their lives and what they think will get them there. There's a group called Shatterproof who does a ton of really great work, specifically around advocacy and combating stigma. So I have included that organization here in these slides and listed a couple of kind of critical points that they make that really do show us how much work we have to do, but where we can actually start making some changes. You know, years ago, we started talking about substance use disorders as a chronic medical condition, which was great, right? We were banging the drum for years and years and years. It's not a moral failing. It's not a moral failing. It's a chronic medical condition. And people said, yes, 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 I get it. I get it. The reality of it is, I think we have figured out how to call it a chronic medical condition, but aren't necessarily treating people any differently than if we thought they had a moral failing. And I think the statistic that Shatterproof uses a lot sort of shows us that fewer than 20% of Americans said they were willing to associate with somebody who was close to them who was also addicted to prescription opioids, right? We say, you know, we're saying we get it until it's close to us. And that's, I mean, it's just a hard, nobody wants to see a family member struggle with an addiction, but the reality of it is, we say that in an intellectual way, and I don't know that we've changed that much about how we really treat people around us. So just consider that. Another just deeply disturbing statistic is the disparity in the rates of access to medication-assisted treatment. White Americans are getting it a lot more than they used to be. Great. People of color, not nearly as much. So as we build these practices, as we promote these practices, we have to think about what audiences we're not reaching. And again, I'll talk about language over and over again. There's tons of good evidence that says the way we use language sets up the way we perceive the people with substance use, and the way the people with substance use perceive their capabilities and their own sort of sense of self. So anytime you can just pause before you use words like addict or junkie or any of that. Honestly, I prefer not to use clean as well. Sober, great. Recovery, great. People aren't clean or dirty when they use substances. They're people. So that I'm sure is all the time I had. Thank you guys so much. As you can tell, I really like this stuff. So anyway, thank you for having me. In some other moment, in some other venue, I'm happy to answer any questions or engage in much more dialogue.
Allison, thank you so much. I literally could listen to you talk forever. I do want to talk for just a second about harm reduction, and to be totally honest, as a 911 provider, it took me a long time to buy into harm reduction. I'm not going to lie. I felt like I was giving people permission to do drugs. I'll tell you though, I know that you didn't like the word, but the single most profound statement I ever heard was when someone said, dead addicts don't recover. And I just want you to think about that. People need to understand that when you have congestive heart failure because you ate too many Big Macs and you smoke 5 packs of cigarettes a day and you get on congestive heart failure medication, people don't really judge that, and you never get off of the medication, and you go to the hospital all the time. Your quality of life is terrible, and it impacts everyone around you, especially the 911 system. When you're on MAT, people seem to think that that is a substitute for the drug, and that they don't seem to understand that it is a medication and it's a treatment, and it is exactly the same. You wouldn't expect someone to quit their diabetes medicine because, well, you should be over it by now. And if you just did diet or exercise, you could be off your meds. That is true. And some people successfully wean off of their MAT, and great for them. But that is not everyone's course. Yeah. So before I get too emotional on that one, said too, thank you so much for your words. And again, with the power of recovery, let's talk to Sam Nishi, who's the program manager at Oregon Recovers. Sam Nishi has a role in which he oversees a variety of Oregon Recovers community building and direct services projects, including Oregon Recovery Network, the Walks for Recovery, and Recovery Community Summit. He is a harm reductionist and recovery advocate who is passionate about centering the voices of people in recovery and people who use drugs in the healthcare system. I can't wait to hear what you have to say.
All right. Thank you so much, April, and I really appreciate you sharing that as well. You know, that's something we hear a lot. I also volunteer in my free time for Portland People's Outreach Project, which is a syringe exchange up here in Portland. I'm coming here more from an Oregon Recovers perspective today. So yeah, just a bit of background on Oregon Recovers. The goal is to basically create a recovery-oriented system of care in Oregon. Our system of care has great elements to it, but they're really not as connected as we want them to be. And those disconnections are the gaps in which people, we lose track of people, and they're not able to continue on their goal of recovery or whatever that path looks like. And we're working for a system that makes recovery a possibility for everyone, recognizing that, you know, it doesn't look the same for everyone. You know, we know Black and brown people, LGBTQ people are disproportionately impacted by the drug war. So, you know, it's going to look a lot different for folks of color than it is going to look for white folks and other people. Yeah. And yeah. So just to go in a bit into sort of the crisis as it stands in Oregon. I know other folks have touched on this a bit, but we lose 1 to 2 Oregonians a day to drug overdoses, another 6 to alcohol-related deaths, which include both the direct impacts of alcohol as well as things like drunk driving. We have 9.45% untreated addiction rate, which I believe is the 5th highest in the country, but our access to treatment is the 47th lowest in the country, or the 47th in the country. So we have the highest addiction rates, but the lowest access to treatment are among that. And what that all adds up to is we lose 2,100 Oregonians a day. Heart-wrenching number, obviously, or excuse me, not a day, annually. Still a heart-wrenching number. This past year I lost my first friend to an overdose, and it sucks. The past year, COVID considering, has been a tough year for the recovery community and the recovery community as a whole. But yeah, I'm going to tell you a bit now about the work we're trying to do. And so basically, the bigger overarching goal of Oregon Recovers is uniting the recovery community. We know if we can all come together, then we are this powerful force. And we define the recovery community as folks in recovery, friends and family of folks in recovery, and the recovery workforce. And one thing that really, strengthens our community is looking at it in a way of, you're in recovery if you say you're in recovery. No conversation of recovery and harm reduction can really be had without sort of acknowledging that there's often an animosity between the two. That I see a lot, coming as a harm reductionist and for the past year and a half about working in the recovery field, often see conflict between the two, misunderstanding between the two. But when it all comes down to it, harm reduction and recovery were both sort of created to keep our communities safe. And how they were created looks different. We can't mention harm reduction without mentioning that it's a movement that was started by people who use drugs, started by people of color, and started by people who do sex work. That's a fact. Recovery, as it's in its most traditional sense, and the 12th step was started by older white men. And that's a conversation we need to have. It's not going to work for everyone. And it does work for a lot of people, though. And the goal of both is to keep your community safe. And I think, that's just how we need to approach all this. And I put up there as well, the third tradition of AA transfers over to NA as well, with just a switch in a couple terms. But the only requirement of membership in AA is a desire to stop drinking. So that really is another way of saying, you're in recovery if you say you are. You don't have to be abstinent or whatever you want to call it. But, you're in recovery if you say you are. And if we can all come together as a community recognizing that, we have the power to create that change. And so I just threw up here the recovery continuum of care. It's a bit of a simplified one, but moving from prevention to intervention and harm reduction, treatment, and recovery supports. I think looking at this, it's easy to pigeonhole recovery as something that just takes place within the recovery support section. But the way we need to look at it is each stop along this path and anywhere in between is a way that we can incorporate recovery, where folks can build the skills or make steps towards recovery, whatever that looks like for them. And I think as we move on to the next slide, that's clearly shown, if we look at SAMHSA's elements of a recovery-oriented system of care, a continuum of care is just one of those elements among many others about how we can build recovery throughout. Yeah. And so in terms of Oregon Recovers approach, I'll try to speed along on this part. Our big three sort of pillars are building community, building power, and then creating policy change. And I'll tell you a little bit about how we do all of those. So our biggest community building event are the Walks for Recovery. We've got 5 this year. Please go to that site there, register for the Walks for Recovery, come out and show support for the recovery community. There are big pride-like events that sort of generate pride with it in recovery. A lot of it still is, based in being anonymous, but we can't have power if we're not showing up. So yeah. In terms of building power, some of the big things we've done, each year we host an advocacy day, which I forgot to put up on this slide, but where we bring folks in the recovery and in the recovery community down to Salem, try to get somebody from every legislative district. We have them talk to their legislators, tell their stories of recovery. And that has helped us build some momentum and really empowers the recovery community to know that they have a voice. We've also, gotten Governor Brown to declare addiction a public health crisis statewide, and had local resolution passed in, the biggest municipalities in Oregon, declaring addiction a public health crisis. And we also try to build up the skills of folks in the recovery community through events like our Recovery Community Summit, which will be in its 3rd year this year. And in terms of policy change, we really worked, and this is something I have more of a surface level view of because I haven't worked as much on the policy side, but we build that power and we try to translate that into creating change at the state level and at local levels. And we've successfully had bills passed that have helped establish a statewide strategic plan for the Alcohol and Drug Policy Commission to reinvigorate itself because it was pretty latent at the time that Oregon Recovers came around, and build a plan to transform the system of care in Oregon. And we continue to work towards that. This past year, we proposed a few bills that would really transform the recovery community. We weren't successful in any of those, but we did for the first time really move the dial against the alcohol industry in terms of trying to make them pay for the harms they cause and build up the strength of recovery in Oregon. Also at the beginning of COVID, we sort of transitioned to a bit more of a direct service model in some ways. We created Oregon Recovery Network because we knew in this time of isolation, recovery resources were not as available to folks. So we created this site where people could initially just find online recovery meetings, and then it bloomed into other resources. And now we have a peer connection service where we can connect anyone in Oregon with a peer. Yeah, that's all I got for you. Thank you so much for having me.
Thank you very much for that information and for all the work you do, especially with legislation, because I know that, especially in times of COVID, getting people to sit and listen and really make change, it really only happens from the top down. We can spin our wheels all we want and spread all of the news campaigns, but until it's really adopted and made policy, it's difficult to make those changes. Thank you, all the speakers that had things to share today. Your information was incredible and really useful to those of us that were listening. To the participants of this class, I want to thank you for coming and taking the time to have this. Responding to emergencies can be really frightening. I happen to love it, but for most people, it's fairly frightening. And so the fact that you're taking the time to figure out how to respond and be prepared, hopefully takes some of that fear out, gives you the confidence to respond, and then all the rest of the information can give you the ability to share with others, and one by one, even if it doesn't come from the top down, just word of mouth, hopefully we can all just change the stigma behind addiction and recovery and substance use, and treat it like the disease that it is, and really work to better everything for everybody, especially those suffering with substance use. There was one question I saw in there that didn't get answered, so I'm going to just address it right now. Michaela, you talked about CPR with rescue breathing, and I'm going to just clarify by we typically, I'm guessing that May brought up rescue breathing because we don't have a whole class to teach CPR, because when the opioids attach to your red blood cells that carry the oxygen, it stops you from being able to breathe. And so the first thing that happens when you have the opioid overdose is that you stop breathing. And that's typically when people notice something that's going on. And you have some time in there to reverse that before your heart actually stops. And so, yes, absolutely. If someone doesn't have a pulse and they're not breathing, yes, compressions. If you don't want to do mouth to mouth, I get that. And compression only CPR is proven to be effective. But with naloxone, we can get rid of the opioid that is depressing the body from being able to breathe. And so we talk mostly about rescue breathing instead of going full into CPR, although oftentimes they do go hand in hand. So I hope that answers that question on that. And then, of course, Clackamas Fire puts on CPR classes, so anyone is always welcome to check on our website for classes. I want to ask real quick before we transition into the video about administering naloxone, if anybody has any questions that we didn't have a chance to answer, go ahead and unmute and ask them now. All right, I'm going to hand this back over to Elizabeth then. She's really what kind of helped bring this to us as part of the task force. And thank you again all for letting me be a part of this and spread the word. All right, have a good day, you guys.
Thank you. Amy Jo, are you going to be available for a few more minutes? I think May will show the video. And if you have any like those questions that Amy Jo was able to help, once you see the video and you have some questions about administration, we'll be there to ask to have her answer them. Are you able to pull up the video now, May?
And I will answer those questions, but honestly, I think that a lay provider, someone that's not a paramedic answering those questions might actually be a little more credible than me for this one, because I have a different insight to things. And so May, if you want to answer those questions, go ahead. If there's something you need to defer, I will be here for that.
All right,
That's
sounds
great.
Yeah.
And did we didn't really discuss the different forms of naloxone. Did we during the presentation? Maybe before we go to the video, maybe we should touch on that. We talked about the nasal formulation, which I've got here, which is pretty easy to administer, kind of like what Amy Jo said, kind of that lay person type of administration, but there's also different formulations. And May, do you want to discuss that and the availability of those different?
Yes. So there's the nasal one, and then there's the intramuscular kind, which comes in a little vial. And you put it in a syringe, and then you find any fatty part on the person, and you can just put it right into their muscle. Elizabeth Smith has some of that available, I believe. If she doesn't mind putting her email in the chat, and she can provide people with that kind if they want. And yeah, that can go over clothes even. So you would just stick it into their muscle, and it works just the same as the muscular one, or I mean the nasal one. And then there's also one that's kind of like an EpiPen. We don't supply those ones, and I think they're much more expensive. So, but it works just like an EpiPen does. And yes, I believe that's all the kinds. Correct.
May, I was just going to suggest when we send out an email to everyone after this event with resources, we will attach videos for both the intramuscular and the one that May is going to show, which is for the nasal formulation.
Yes. So I'm going to share the nasal one now. If you can't stay, I totally understand, and we will link the video in a follow-up email. But yes, let me.
Before everybody goes, just please get naloxone. You saw we all had it. Just look at those, how email us, let us get it to you. So if you can't stay, please contact us to get naloxone.
Yes, and Elizabeth Smith just put her email in if you want to get the intramuscular kind. And we do have the nasal one. And I linked the form you would fill out to get that. So let me.
Naloxone to reverse opiate overdose. Naloxone is a
Can everyone hear
medicine
that?
and is also known as Narcan. When someone overdoses on opiates, they stop breathing. Naloxone reverses opiate overdose so they can breathe again. Opiates include drugs like heroin, methadone, OxyContin, Vicodin, Percocet, codeine, and fentanyl. Naloxone does not reverse overdose from drugs like cocaine, meth, alcohol, or benzodiazepines like Xanax or Valium. Step 1. How do you know if someone is overdosing? There are several signs. Not breathing, or breathing is very slow or shallow, turning pale, blue, or gray, especially in their lips or fingernails, making snoring, gurgling, or choking sounds, becoming limp, throwing up, or not responding to yelling or other stimulation. The quickest way to see if the person is responsive is to take your knuckles and rub them firmly up and down the person's chest bone. If the person does not respond, check for breathing. Watch their chest to see if it rises and falls. Put your ear near their face to listen and feel for breaths. Step 2. Call 911. If the person does not respond and is not breathing, call 911 immediately. There may be complications that need medical attention, or the person may have overdosed on something besides heroin or other opiates. Emergency medical services are critical. Step 3. Rescue breathing. If the person is not breathing, start breathing for them. First, make sure their airway is clear. Check for food or anything else in their mouth. When their mouth is clear, tilt their forehead back and lift their chin. Pinch their nose and give them one normal breath every 5 seconds. Continue doing this for about 30 seconds. Step 4. Give naloxone. If the person is still not breathing, it is time to use your naloxone. Your kit should include at least these 3 parts: an atomizer, a vial of naloxone, and a plastic applicator.
I just realized I pulled up the wrong video, but this will show how to do one of the kinds of naloxone, and I'll link the rest of them in the follow-up email.
First, take the yellow caps off the applicator. Then take the cap off the naloxone. The naloxone container is made of glass, so be careful not to drop or break it. Screw the atomizer to the top of the applicator using the plastic wings. Insert the open end of the naloxone into the wide end of the applicator. Gently twist until you feel it catch. If naloxone leaks out of the top of the applicator, stop twisting. Each vial contains 2 milliliters of naloxone. Spray half the naloxone up one nostril until you reach the 1 milliliter mark. Switch nostrils and spray the rest of the naloxone. Step 5. Give more rescue breathing. It may take several minutes for the naloxone to kick in. Brain damage can occur after 3 to 5 minutes without oxygen, so you need to breathe for the person until the naloxone kicks in. Give one breath every 5 seconds. If the person has not woken up after 3 minutes, give them a second full dose of naloxone. Continue giving one breath every 5 seconds until they wake up or until emergency medical services arrive. Step 6. Follow-up. If the person is dependent on heroin or other opiates, they may go into withdrawal after you give them naloxone. Withdrawal symptoms can include vomiting, diarrhea, sweating, and agitated behavior. This may be unpleasant and dramatic, but it is not life-threatening and only lasts until the naloxone wears off. Tell them that naloxone wears off in 30 to 45 minutes and there are still drugs in their system. Within 90 minutes, the withdrawal effects will be gone. Watch the person for at least an hour or until emergency medical services arrive in case they go back into overdose. When they wake up, keep them calm. Recommend that they seek medical attention and help them if necessary. Do not let them use more heroin or other opiates. The naloxone will block it and they could overdose again once the naloxone wears off. Recovery position. If you have to leave the person at any point, put them in the recovery position. Roll them over slightly on their side. Bend their top knee. Put their top hand under their head to support it. This position should keep them from rolling over onto their stomach or back, so they won't choke if they vomit. Prevent overdose. Opiate overdose is most common when your tolerance is down after you take a break from using, when you mix drugs, especially combinations of downers like heroin, methadone, or other opiates, alcohol, and benzodiazepines, when you've been sick, tired, run down, or dehydrated, or when you use stronger drugs than usual. To prevent overdose, go slow after breaks, or if you're using something stronger. Be careful when mixing drugs. Take care of yourself. Eat, sleep, and drink water. Review. If you think someone is overdosing, check for responsiveness by rubbing your knuckles hard on their chest bone. Call 911. Breathe for them for 30 seconds. Give a first dose of naloxone. Continue breathing for them for 3 minutes. Give them a second dose of naloxone if they have not woken up or started breathing. After they wake up, monitor them to make sure they do not overdose again. Put them in the recovery position if you have to leave. Refills. Ask your trainer how to get refills and
All right, so the naloxone we have looks a little bit different, but it's the same idea. You just put it up in one nostril and then wait the 3 minutes or so. If they don't wake up, you can use another dose. So, but I will make sure I have the correct video in the follow-up email. So, does anyone have any questions? No. Thank you all for coming and listening to us talk. I will put my email in the chat if anyone needs anything from me or has any follow-up questions, but you will be hearing from me in the next day or so with more resources. So,
Thanks, everyone.
yeah, thank you.
Thank you.